Good evening, and welcome to the University of Chicago Francis and Rose Yuen campus in Hong Kong for our 6th Global Conversation live event, 100 Year Lives in Asia, with Professor Kate Cagney. My name is Mark Barnico, and I'm the Executive Director of the University of Chicago Francis and Rose Yuen campus in Hong Kong. We're broadcasting tonight's event via Zoom, Facebook, and YouTube Live from the Hong Kong Jockey Club Academic Complex on the Yuen campus. If you have questions for any of the panelists, you can submit them through the Questions and Answer tab by first registering on Zoom. The Yuen campus in Hong Kong is the University of Chicago's premier location in Asia, which represents our UChicago values of free and open discourse, rigorous debate, and the exchange of ideas. I encourage you to visit our website at uchicago.hk for news and information on the latest events hosted by the University of Chicago Yuen campus, or follow us on the UChicago Yuen campus Facebook page. The 100 Year Lives in Asia series is one of the new programs developed and produced under the Yuen Lecture Series banner by Kate Cagney and the UChicago Hong Kong team. I want to make you aware that we'll begin our next Yuen Lecture series entitled The U.S. Presidential Election with UChicago political science professor William Howell, beginning on September 10th. Tonight, we're again delighted to welcome Professor Cagney from the University of Chicago Sociology Department to host the 6th of 7 episodes, Government Policy and Social Safety Nets. This evening, Professor Cagney will discuss the impact of government policy on aging populations with an expert panel joining the discussion. The current pandemic has touched all of our lives. COVID-19 is even straining our birth rates, which are already in decline in some countries. The global population of 7.8 billion people is expected to peak around 9.7 billion in 2064, before it begins to decline again to 8.8 billion at the end of the century. As fertility rates continue to decline, populations in countries like Japan could decrease by half, from 127 million people to 53 million by the end of the century. This new reality will have extreme consequences on government policy and the social safety net. With more elderly than young people, governments will have to deal with new issues and create new policies. For example, who will pay the aging population's living and healthcare expenses? Where will companies find workers? Will immigration need to increase in certain countries to meet worker demand? Or will more elderly workers remain in the workforce? Are governments ready for the weight of aging populations on existing programs, or will they have to develop new ones? How quickly can they respond to the new challenge? One remaining episode of 100 Year Lives in Asia will be broadcast in the month of July. Our 7th and final episode on July 30th is entitled, Where Do We Go From Here? It will focus on innovation and opportunities. We have an excellent panel already lined up for that conversation with Kate, so please plan to join us on July 30th. And please don't forget, you can find the previous 100 Year Life in Asia episodes on our uchicago.hk website and on our YouTube channel. Now I'd like to get to the program and introduce the chair of 100 Year Lives in Asia, Kate Cagney. Professor Cagney is a professor in the Department of Sociology at the University of Chicago and the director of the Population Research Center, NORC, and the University of Chicago. Good morning, Kate. I'll turn the program over to you.
Good morning, and thank you, Mark. As Mark noted, the last time we were together, we discussed responsibilities across generations in informal care, so the intergenerational transmission of support. Today, we think of another form of responsibility, that of the government for its citizens and expectations for service provision and accommodation. When we address today's topic, government policy and social safety nets, we will discuss vulnerability in general terms, but that which we anticipate comes with aging, but also vulnerability, specifically disability, across the life course and how that's addressed in the context of policy. We'll also highlight differences among nations and what we might glean from one another in terms of governmental approaches to supportive structures. Let me tell you a bit about the experts who will guide our conversation today. First, Vipan Prachuabmoh is a professor and dean of the College of Population Studies at Chulalongkorn University in Thailand. She received her Ph.D. in sociology from the University of Chicago. She's a demographer whose main research interests lie in the field of consequences of low fertility, population aging, and population policy. During the past decades, her research work has focused on issues related to the consequences of low fertility, population aging, including population and plans for older persons. She also serves as a member of the National Strategy Committee on Preparation in the Prevention of Creating Opportunities and Social Equality. She's a member of the National Commission on Elderly, a committee on reforming systems for an aging society of the National Reform Council. And she's co-principal investigator of the Asian MetroCare for Population and Sustainable Development Analysis.
Morning.
Good morning. Thank you for joining us. And she will be joined by Harold Pollack, who is the Helen Ross Professor at the School of Social Service Administration at the University of Chicago. Trained in public policy at Harvard University's Kennedy School, Pollack is co-founder of the University of Chicago's Crime Lab and co-director of the University of Chicago Health Lab. His current NIH-funded research concerns improved services for individuals at the boundaries of the behavioral health and criminal justice systems, disabilities, as I noted earlier, and two major new efforts to address the opioid epidemic in Illinois and across the nation.
Thank you for having me.
Yeah, sure. I'm going to even say a little bit more about you, Harold. He's past president of the Health Politics and Policy section of the American Political Science Association, published widely at the interface between poverty policy and public health, and his research appears in such journals as Addiction, Journal of the American Medical Association, and the American Journal of Public Health. I also wanted to note, too, that Harold shares his work publicly through the mechanism of journalism. His comments have appeared in the Washington Post, The Nation, and the New York Times. And I love this. His American Prospect essay, Lessons from an Emergency Room Nightmare, was selected for the collection of Best American Medical Writing. And so we may want to hear a bit more about that.
Thank you.
Finally, Joelle Fong will join this conversation. She's assistant professor at the Lee Kuan Yew School of Public Policy at the National University of Singapore. She received her Ph.D. from the Wharton School at the University of Pennsylvania. She's an applied economist and has research interests in the insurance and health aspects of population aging. Her current research investigates longevity, risk management and pension systems, old age disability, incidence and functional decline, as well as long-term care insurance schemes. She also serves on the board of the Singapore College of Insurance and is the vice president of the Asian Pacific Risk and Insurance Association. She worked in the Singapore civil service before joining academia, so there's this nice bridge between government and the academy, and in her current role continues to engage with various government agencies on issues of retirement, financial literacy, and population aging. So Joelle is going to start us off, and she'll set the stage for our conversation. Welcome all.
Hello, everyone. I'm thrilled to be part of the conversation, and I would like to thank the organizers for inviting me to join the panel today. So one aspect of my research looks at the role of insurance in helping individuals manage the risk of growing old and its implications on policy. In speaking to the theme of government policy and social safety nets for this episode, I thought I would start off with how different people, depending on age, culture, or nationality, may interpret the term social safety nets differently. The interpretation likely flows from how one fundamentally views the relationship between welfare and work, but one analogy that has been offered is that the social safety net is akin to a hammock. Workers who rely on this government assistance are lulled into lives of dependency and complacency that drains them of their will and their incentive to work. And then there's the other view, that social safety nets can be designed to be tight and stretched out like a trampoline, that social policy and government assistance can be minimalist, but complemented by schemes to improve social mobility, to help people reskill and to bounce back. And given an aging society, schemes that can help cover some of the major risks faced by the elderly so that older persons do not feel that they are being left on their own. Next slide, please. The analogy of the trampoline, there we go. Next slide, please. So the analogy of the trampoline for a social safety net probably best describes Singapore. This diagram illustrates the small role of social safety nets in the Singaporean setting. Yes, we do have financial assistance schemes for needy individuals and their families in order to enhance the capacity of the community, but these are means-tested schemes. And in fact, many people can't even apply for some of these schemes on their own accord. Instead, the government will contact the household in need. Essentially, the culture in Singapore is one that emphasizes individual responsibility as a necessary precursor to government responsibility. The emphasis is on individual responsibility and self-reliance, and this principle of not only individual but family and community responsibility extends into the way we design our social policies. So our social policy in Singapore revolves around three things: pensions, healthcare, and housing, as shown by the picture in blue, the three blocks in blue. I will briefly elaborate on the pensions pillar. Unlike most capitalist nations, Singapore has chosen to establish a pension system in the 1950s based on defined contributions rather than defined benefits. The crucial difference between defined benefit DB and defined contribution DC plans is the way that they are funded and thus their respective allocation of risk. Singapore's CPF, Central Provident Fund, is similar to Hong Kong's MPF and Malaysia's EPF. In these DC schemes, each worker pays into an account a fixed fraction of his or her monthly wages. The employer may contribute too. These contributions are accumulated in individual accounts and can be used to purchase assets in financial markets to earn returns. So in this way, DC plans are usually funded, which contrasts with DB plans, which are often pay as you go. Governments that promise to provide their citizens with defined benefits are at risk of insufficient long-term financing for these pension schemes, particularly with increasing life expectancies and a shrinking tax base. And this problem has plagued nearly every government-sponsored DB plan in the world, including those in Asia, such as Japan and Korea, which have national DB schemes. Next slide, please. So Singapore has somewhat sidestepped a potential pension crisis or pension funding crisis by establishing our pension system around the central principle of individual ownership and individual funded accounts. But a standard criticism of what somewhat minimalist social policy, such as that which characterizes Singapore, is that it does not help fully cover enough of the major risks faced by the elderly. So my research looks precisely at two major risks faced by the elderly, not only in Singapore, but around the world, and how the Singapore government has tackled these through risk pooling insurance schemes. So one of the major risks faced by the elderly is longevity risk, outliving their pension savings or private savings. And the policy response in Singapore, as I described, is a risk pooling scheme based on mandatory annuitization. And this scheme is called the CPF Live. So the unique thing about this scheme is that the government decided to offer its own annuities. So in 2009, the government decided to become an annuity provider and offered these annuities, life annuities, to members of the pension scheme, which is a DC scheme. And this really helps hedge the longevity risk faced by the majority of these DC plan participants. And what is also unique about this scheme, as I found through my valuation, is that the life annuities offered by the government are indeed value for money. Through compulsory annuitization, they eliminated adverse selection. And this annuity scheme actually offer a stream of payouts over the lifetime of the retiree that is more than what they put into the product as the premium. So the money's worth ratio slightly exceeds 1. Whereas in US and UK and other annuity markets, the money's worth ratio is around 0.8 to 0.9. Let me move to the second major risk faced by the elderly, and that is long-term care risk. What I found through my research is that Singapore, like many of the other countries which has legislated long-term care insurance schemes, decided to embark on a social insurance scheme to help pool the risk of dependency for the elderly. And through pre-funding, again, it carefully avoids a potential funding crisis sometime in the future, and it makes sure that the people who contribute to the scheme are those who also benefit from the scheme. And in a common risk pool, there is some sense of solidarity, and there's also redistribution. And you can imagine in the long-term care insurance scheme, the redistribution is from those who are less healthy to those who are, from those who are more healthy to those who are less healthy and become long-term care disabled. So I've just shared two interesting schemes, risk pooling insurance schemes that the Singapore government has launched in the recent decade to tackle two of the major risks faced by the elderly. So I will welcome any comments and suggestions in the discussion segment later on. Thank you.
Thank you, Joelle. And there will be much to discuss about the structure of that early investment. And, particularly, I think, some interesting contracts with the US. Harold, may want to comment on that too. And we want to hear about disability.
Great. So, well, what a fascinating presentation about Singapore's social insurance structures. Could you load my slides, please? So, as Kate mentioned, one major component of my own work concerns disability policy in the United States and our incomplete safety net, certainly by comparison to what you've just heard about. Next slide, please. One thing about disability is that the population of people with disabilities is incredibly diverse. And here, for example, is a woman named Mariam Pare. She uses a wheelchair. She was shot at a traffic light. She was hit by a stray bullet she was not the intended victim, and she was left with quadriplegia. She also is a very skilled and successful artist. And this is one of her paintings that she makes and she sells. So she needs assistance with some activities of daily living, but she also is a productive person with tremendous contributions. And there's no one profile of disability, and it's useful for us always to keep that in mind. Next, please. So, in its human reality, disability is a multidimensional and continuous thing in which people have various kinds of physical or cognitive limitations or impairments that interact with the real world environment that they're in. So, for example, I'm quite nearsighted. Is that a disability? Really, it's not in the world that I live in. Or a graduate of the University of Chicago Law School who uses a wheelchair is capable of assuming many economic roles, paying taxes, and requires some services from government, but also doesn't require others. There's if we think about someone who is a coal miner who has minor depression or back pain, you could see that there's a large range of ambiguity. And this multidimensional and continuous reality is never going to comfortably fit within a binary designation within public programs that says you're disabled or you're not disabled. And if you are determined to be disabled, you get a package of benefits. And if you're not determined to be disabled, you will not. That is true in the United States and true across the world, that we have many, many complex judgments that have to be made. I would say that on the whole in the United States, that disability is a success story compared to many aspects of American public policy, obviously public health and infectious disease control being one. We really have made remarkable progress, particularly over the past 30 years since the passage of the Americans with Disabilities Act. Two areas that are really quite notable in the United States where we've made a lot of progress is, one is that adults and children who live with intellectual or physical disabilities are much more likely to live on a human scale within their own communities rather than within an institutional setting. And if we look at, for example, children with intellectual disabilities, the number of people who live in an institution on a large scale has declined by about 97% since the late 1970s. So we really have deinstitutionalized very effectively in many ways. We've also dramatically improved the physical accessibility of public space, and that's something that we should not take for granted. If you use a wheelchair and you compare moving around Chicago with moving around some of the great cities of Europe that actually have more advanced social democracies and some of their social insurance structures, Chicago compares quite well in just the ability to move from point A to point B. I should say, but that progress has been quite uneven in the United States as well. Next slide, please. So I should say my wife and I take care for her brother, who lives with an intellectual disability known as Fragile X syndrome. And this has made us quite conscious of some of the disparities that we see. And one interesting connection to the themes of this conversation is we have an aging society and changing challenges relating to dependency. One of the most difficult challenges in the United States is that we have many individuals with disability who live with caregivers who are often their parents, and their caregivers are getting old. And we have, among people with intellectual disabilities, about 900,000 Americans live with a carer who is over the age of 60. And one of the real challenges that we have is, what is the plan as the carer gets older? And this is particularly the case with intellectual disabilities, because most people with intellectual disabilities live a full lifespan and will outlive their parents. And what we see is very long waiting lists for home and community-based services that often are for those kinds of situations. In the United States, about 700,000 people are on waiting lists for Medicaid services. Medicaid is the predominant health program for low-income Americans. Almost half of those people actually live in one state, which is the state of Texas, and that's a major challenge. A second challenge that we face is that different disabilities experience very different levels of stigma. And we really see that in our household because we are treated very, very well by almost everybody that we encounter. My brother-in-law is very visibly disabled. He's very sort of childlike, and we have almost no negative experiences with anybody. And if he were equally disabled, but he lived with a serious mental illness, it would be much more difficult for us, and we would be much more stigmatized within our community. And I'll give you an example of how that stigma shows up in a very practical way in policy. These two maps are the locations of residential facilities for people living with disabilities. So these are people living with disabilities who need housing supports. And on the left, the dots represent where, this is the city of Philadelphia, Pennsylvania. The dots represent where the facility is located, and the size of the dot is how many people live there. So a small dot is, I'm living basically within a household or some sort of a very small, on a human scale residential setting. And the larger dots represent a more institutional setting where I'm living with a bunch of other people with the same disability, and I'm less integrated in my community. And what you see on the left is for developmental disabilities, intellectual disabilities like Down syndrome or Fragile X, things like that, what used to be called mental retardation, for those of you that may not be from nomenclature. And what you see is small dots all over the city. Every neighborhood in Philadelphia has lots of places where people live who have intellectual disabilities. And most Americans, if you ask them, wouldn't have any particular ideas they're one of these in your own community. People, they sort of shrug and they don't even really notice. On the right, this is for serious mental illness, things like schizophrenia, people with psychosis-related issues. And what you see is many, many fewer dots. They're larger, they're more institutional. And what you can't see on this map, but which turns out to be true, is they are much more concentrated in lower income communities. And so what's happening is there's a greater stigma, and the more socially advantaged communities are not welcoming of people with these types of issues who require those services. So I would just say that I very much welcome the conversation about disability. We have very significant challenges in an aging society, not just to take care of aging people with disabilities, but also to take care of younger people with disabilities who rely on family members and others to care for them. And our American society has definitely made progress in being more inclusive, but it's uneven progress within an incomplete safety net and within a society that has incomplete acceptance for people with disabilities. So I'll stop there, but those are some thoughts that I have for my own research in life.
Thank you so much, Harold. And we definitely want to get back to the points about the intergenerational aspects of care and the older caregivers and this notion of stigma. So Vipan, let's
Yes.
to you, and then we'll have a broader conversation.
Okay, thank you very much. I am pleased and honored to take a part in the University of Chicago webinar series, 100-Year Life in Asia. I would like to thank the organizer for inviting me to participate in this series. First, I would like to give a brief overview of the population aging in Thailand. Thailand is a good example of developing country that getting old before it getting rich. Thailand has entered an aging society since the year 2000, while Japan has entered an aging society 30 years earlier. However, the GDP per capita in Thailand is about 6 times lower than Japan when aging process began. Thailand is the second most rapidly aging in Southeast Asian country and ranked number 8 in Asia. Population aging in Thailand will become far more pronounced in coming decades. Not only the share of older persons among the total population, but also the share of oldest old population is also increasing. In Thailand, the government started to consider aging issues seriously in the mid-1990s. A second national plan for older persons covering 20 years adopted in 2002, coinciding with the UN-sponsored Second World Assembly on Aging. I would like to focus my talk on 3 dimensions of policy and social safety nets for Thai elderly: housing, healthcare access, and economic security. In terms of housing, the first home for older persons was funded in 1953 to provide housing for abandoned or destitute older persons. Later on, the home for ages were transformed into social welfare development centers for older persons due to the culture of filial piety. Institutionalized care is considered as last resort to be provided by the government as a social safety net for persons in need of elder care. Thus, there are only 12 centers in every region across the country, supported by the national government under 2,000 residents, and other 13 centers under the local government. Concerning healthcare access, universal minimum cost of free health coverage at the government facility has been available in Thailand since 2001 for all Thai nations, regardless of age. However, persons ages 60 or over have been entitled to free government medical service since 1992. The Thai government is clearly aware of the challenges that long-term care poses in the context of decreasing availability of family assistance due to very low fertility. A pilot project on the community-based long-term care was launched in 2008. And since 2016, the Thai government has expanded the community-based long-term care program. This program is based on the concept that the quality of life of older persons at more advanced ages can be best retained through assistance within their family and support system of healthcare and social service within the community. In terms of economic security, although the family remains valuable source of financial support for older persons, the significant expansion of the government sponsored program has been taking place. The government pension scheme for older persons in Thailand was originated from 1951 Pension Act for civil servants. Only government official can get pension at that time. In 1999, an older age pension fund within the National Social Security System for all workers in private sector was set up. 6 years later, the National Saving Fund provides retirement benefit cover for self-employed and employment sector was launched. In addition, the government has provided old age allowance since 1993, which was the first mean tested, and later on, since 2009, became universal social pension for Thai elderly who do not receive any other form of pension or benefit from the government. Recently, the first national strategy has been implemented as a long-term goal for nation's sustainable development. Population aging and welfare of older persons are featured quite prominently in Thai national strategy. This strategy is expected to enhance continuity of the country aging policy with limited resource to cope with the very fast speed of population aging and tendency of living longer. The national strategy gives high priority to human capital development, especially through lifelong learning. The present government attempts to develop a flagship program response to aging society. This program comprises of 5 main measures: encouraging the younger generation to prepare themselves in all dimensions to be quality aging, expand fundamental security for aging society by promoting voluntary saving for older age, and try to expand the long-term care system. Empowering 3 generations for involvement in social development, and creating support environment and innovation for all. And the last one is promoting the integrated management system response to the aging society. Although Thai government response to population aging has been increasing vigorous, the rapid demographic transition combined with disruptive technology and innovation and socioeconomic consequence of COVID-19 pandemic may be obstacles for policy implementation. The current negative socioeconomic situation has pushed older persons to become most vulnerable group. In sum, in the context of disruptive and unexpected changes, we need more resilient and effective policy program. The lesson learned on policy implication and the COVID pandemic impact from the other countries can be very useful for formulating appropriate policy in Thailand. Thank you for your attention.
Thank you, Vipan. And actually, you teed this up well. I think we should begin with a conversation about COVID. We have a listener who's asking what special measures are in place for the elderly during the pandemic, and wondering, we want to think about how these social safety nets can be employed or not in the context of COVID, particularly since we don't really understand yet what the arc of the experience will be.
Yeah, in the case of Thailand, in the rural area, we have health volunteer system. During this COVID, pandemic, they came to visit every house, and they try to help the older person or the and their families. So they send the medicine and the food. So it helps older person who have the chronic disease, so they can get continually get the medicine. Okay, and then they also, if they have a problem, they can have a food. It's very good system in rural area where the community tie is very strong. But in the place like Bangkok, I think it's really poor. Yeah, and pity for older person because some of them very, very poor. And then during this period, some of them cannot get out to see the doctor. They cannot get medicine. Some of them lost their job. So now I think that the government need to have some kind of program of, some kind of social safety net for older person or for the urban poor. We need a special kind of measures. And yeah, so now I think one thing that the government try to do is they try to make a reformation on data because we know that we don't have up-to-date data because in Thailand we are free to move, so they don't need to register. So in the big city, everyone like in Bangkok is like a primate city. Everyone just moved to Bangkok without registration. So we don't really know how many people in Bangkok. So it's like latent population that they cannot get any help because they're not registered. So now we try to do another, collect all the data of all people who residing in Bangkok, not whether they undocumented, they need to get some help. Yeah.
Harold, would you like to jump in on that comment and help us think a little bit about disability in the context of COVID?
I was frozen slightly. So I heard talking about disability in the context of COVID. It is a very, very difficult challenge on multiple levels. First of all, there's a risk of actual COVID infection that is enormous among seniors and people with disabilities because they're physically more vulnerable and also because they're living in crowded housing situations. In the United States, almost half of the people who have died are people that are in nursing homes and related facilities. And some of that reflects a failure of the management of these facilities, but some of it also reflects the inherent difficulty of keeping infection out when it's in the general community more. And we also see very high fatality rates among seniors who are members of racial minority groups who tend to be in communities where COVID is most severe. Among individuals with intellectual disabilities, the toll has been less severe because of the deinstitutionalization. So my brother-in-law he has 3 or 4 other roommates, and so he's not living in a big institution where there's more risk of a rampant spread. But in some of the facilities for people with intellectual disabilities that are more institutionalized, they've also been hit pretty hard. Lower fatalities because people are less physically vulnerable, but high infection. One thing that we've seen among seniors is the American economic safety net for seniors is better than the American economic safety net for younger people. So many seniors are insulated from some of the economic consequences of COVID because they continue to get Social Security and Medicare, but they are also very socially isolated, lonely, and frightened. And also just things like, can I access other people through the internet? People with disabilities, seniors, may not be connected to the internet or may require some additional help. And some of the most effective services are things like coming to someone's house with like an iPad that has been simply programmed so I can push a button and see the newspaper, or talk to my grandchildren without having to have digital proficiency. And one of the bright spots in the US is a lot of younger people, often, younger than 25, are saying, how can I help? And they are delivering meals to seniors, helping people with internet issues, things like that. And I think I hope we can really build on that once the COVID crisis has passed, because this is also the future public health and social service workforce. young people who say, hey, I want to contribute, I need a job, and I want to contribute. So those are some things that came to mind.
Thank you. And Joelle, could you comment on the context of COVID for the sorts of protections that are in place? And I love this notion of the trampoline. So I want to see if you could tell us how that is employed in a moment where, right, we have so many people who are in need.
Yeah, so in Singapore, the social assistance stemming from COVID-19 is short-term to medium-term assistance. So it's we have the temporary relief fund, for example, that was set up right in April, back in April, and as well as the COVID-19 support grant. And these are financial assistance for people who are involuntarily unemployed due to retrenchment or due to the business closing because of COVID-19. People who have experienced a reduced monthly salary of at least 30%. For at least 3 consecutive months because of the economic impact of COVID. So certainly there is this financial assistance, and it's really not about, it's about tiding people through this difficult period, and once the economy recovers, help them bounce back up in that sense. And the government has actually encouraged firms and companies during this difficult time to actually hold on to their workers. So it disperse some money to the firms directly to help them hang on and keep their workers rather than retrench the workers during this time. So monies have gone to individuals, have gone to the firms, as well as other grassroots organizations to help, say, some of the elderly who face social isolation during this period. And in Singapore, I think much more so than US, at least while I was living there. The elderly tends to like to congregate at the hawker centers or food centers in Singapore. That's where they talk to each other, gossip, exchange their children for marriages and things like that. So it's quite different, and this suddenly they feel that they can't do that anymore, and that really poses a social problem.
And that reminds me of something Vipan had earlier. It also comes in as a question from a listener. Even thinking about the needs of congregating, one may be able to employ them more readily in an urban rather than a rural area. But then in a rural area, there may be more informal infrastructure and more proximal family to help in terms of assistance. So different possibilities. But with increasing urbanization, do we need to think about these social safety nets differently? Vipan, do you want to comment on that?
Yeah, I think so, that we need to rethink about this. And one point that I'm really concerned that, especially for the social safety nets for older person, because in the past, during the past 2 decades, the underlying paradigm for policy response to the population aging in Thailand is active aging, which emphasize promoting older person to remain engaged in economically or socially productive activity as long as possible. But during the COVID pandemic, this paradigm has been challenged by new normal or stay home and social distancing. So it is a time for us to seek a new strategies and measure to make older persons still active and healthy while staying put. So I think this is one of the challenge. And another challenge that I think is quite serious is that due to lower human capital and lower technology skill than younger generation, the older person are less likely to be employed. Because like now, the government try to promote older person to work, but it looks like that with the after the COVID, the speed of AI and robotic technology may reduce the chance of older person to get a job. So yeah, so now I think that this is one thing that we need to concern, that the government should try the way to manage the technology and AI, AI and robotic technology to in terms of try to reduce the gap between generation, because in Thailand during the COVID period, The older person can use the mobile phone, but most of them cannot use smartphone. So they cannot chit chat like other groups, so they cannot get information. Yeah, because in Thailand, I think that during the COVID period, people listen to the government every day through the television or social media. We keep get informing. Yeah. So, but older person are those group that they cannot because they don't have smartphone, they don't have internet or something like that. Yeah. So we have another thing that's about the gap in terms of technology accessment and technology should use. Yeah.
And Harold, one thing we see, of course, in the United States is a very significant divide in terms of the ability to draw on the kinds of technological resources that one could in this period. So I wonder, Harold, if you want to comment on that. And also, you know, you've done so much work on opioid use, you did in Illinois and nationally, and I was thinking about that in the context of the urban-rural piece too, and drawing on supports in this time of need.
Yeah, it is. You've identified a bunch of things. I think COVID has brought out some very serious disparities. Access to technology and comfort with technology is one of them. Just in so many ways, people with resources have been able to protect themselves against COVID and to stay vibrant in ways that's harder for people with less resources. There's one of the striking things is there's been an incredible increase in the sale of home fitness equipment. And a lot of affluent people are buying fancy exercise bikes and joining gyms where they have their smartphone set up and they're doing a workout at home and with things like that. Or they're able to leave a high prevalence area and spend time in a place where they can get around more. It is, and it's just if you have more money, you can just do more things to go around the constraints of COVID. In terms of the opioid epidemic, we do see that there's been tremendous public health, mental health consequences of COVID. There's a very big increase in people who have anxiety, depression, substance use. You know, you're sitting home, you're bored. You have your liquor cabinet, you have whatever prescription drugs you have, and there's nobody supervising you. You don't have to show up at work on time. So you don't have the structure of daily life. And by the way, if you start to overdose, there's no one else in the house who might be able to call for help. So there is a real concern that overdose fatalities will go up because people are using drugs by themselves. So there's no question that we have tremendous mental health and substance use issues that COVID is aggravating.
Mm-hmm. Joelle, I wanted you to comment on that too. And also we had a question from a listener who came in that essentially asked, are older adults in Singapore satisfied with some of these kinds of structures that are in place? I mean, they seem quite intentional, and it does appear that they've been productive in this circumstance. But I wonder if you want to say a bit more about that.
Right, sure. So in the case of Singapore, the two schemes that I talked about, the long-term care insurance and the longevity risk management scheme, both started in the last decade. So they're pretty new. So for example, the CPF Life was only rolled out in 2013, and the long-term care insurance CareShield Life scheme was rolled out in only, in fact, it was announced last year, but it will only be launched at the end of this year. So clearly these are very new and in the works. And how have Singaporeans reacted to that? I think because both schemes are mandatory and they just have to participate, most of the people just go with the flow. And as we know from many studies that have been conducted in the US, UK, and elsewhere, pension plan participants tends to be defaulters. So they just go with the default, and if the default is to annuitize, then they just annuitize. Very few people actually make active choices within the pension plans and insurance contexts in that sense. But whether they're happy or not, I do not really know. But what I think it's important is for them to understand the products that they are buying into. So it's sort of forced onto them, but they, at the end of the day, it's their money that they have invested in the life annuity and their money that they have contributed to this long-term care insurance since from age 30 onwards. So that's a long-term commitment, and they have to understand the workings of such products and whether they are, at the end of the day, value for money.
So let's move the notion of satisfaction or happiness to one of empathy. We have a listener who has asked whether this COVID experience has made us collectively more empathetic toward the needs of those who are vulnerable. And will that translate into policy in particular ways because we have been sensitized to what it means to come together and be dependent on one another and rely on both our family networks and our communities? And that's a collective question. Harold, why don't you start us out on that one?
Thank you for that question. That is such a great question. I mean, I always thought the fundamental argument for social insurance is that we can act collectively to protect each other against risks that would just crush any one of us if we had to face it alone. And empathy is a big part of that. I do think that COVID is increasing empathy because it is such a catastrophe that requires collective action, and the human face of it is so poignant. And I think that there's a demand when people look to elected officials. I think the elected officials who are able to show empathy in this moment are getting much greater public support than those who are struggling to do that. It is, and I think linking listening to these presentations, linking the need for empathy as at a moral and human level with the need to have effective programs that are sustainable and properly designed is the challenge, because we have these very serious long-term challenges to have a sustaining social insurance structure that is economically viable, that expresses that empathy in a feasible way. And I've learned a lot listening to the presentations today about how I think in some ways Thailand and Singapore are more successful than the United States in doing that.
Joelle, would you like to comment on that? And thinking about, I love this notion of activating empathy toward policy ends.
I think the spirit of collective responsibility really comes together hand in hand with this notion of universal coverage, which we have tried to implement through our policies and through these mandatory schemes. So at one end of the spectrum, you might think that this is forced onto you. You have to participate whether you like it or not. But at the other end of the spectrum is about universal coverage and about coming together as a nation and helping each other pool the risk and diversify away the risk that all the elderly face. For example, in this in designing our long-term care insurance scheme, as to be launched at the end of this year, the policymakers have alluded to this notion of collective responsibility by including persons with a pre-existing severe disability in this risk pool. So we are not excluding or deliberately excluding those who are already have the risk, but we are including those who are at risk and already disabled. So in that sense, we want to strengthen the collective responsibility, which is fundamental to an inclusive and caring society.
Yeah. And Vipan, I'd love for you to comment on that too, and perhaps provide an illustration of how your own work has been translated into policy.
Okay, yeah. I think this time it is really important for collective responsibility in the crisis time, because I think in case of Thailand, we can see it clearly because people start to calculate between the individual benefit and the public benefit. And now when they see the situation like COVID pandemic, people start to think about the country, about the community, about the older person more than in the past, I think. Because now we realize that although we have freedom, but our freedom has to be responsible for the nation as well, for the survival of the nation. So I think that the COVID crisis pulled together all the party like even the private sector try to help in terms of social safety nets as well, because they cannot survive if the country not survive. So this time I think it's a good time to launch some kind of policy that private sector can come and help, because in the past in Thailand, most of the policy was done by government, and mainly or family responsibility, either family or the government, but the private sector never participate. But this time of crisis, I think that the private sector understand that they need to come, cannot survive too. Yeah.
And I'm glad you raised the private sector, because we had a question from a listener who asked, are there examples of private sector, public-private partnerships that have been successful in either building community or kind of creating, let's just say sort of a micro level safety net in some of these circumstances?
Yeah, because I mean, in this situation of COVID crisis, right? You mean, in Thailand before,
for populations who are vulnerable.
Yeah. In Thailand, I think that during the past 5 years, the government tried to have some kind of the collaboration between public, private, and sector, and I mean people involvement as well. And then they do some kind of help people in the village in terms of try to have the community enterprise or something like that, because they try to have small scale of industry in the community area. And so they ask the private sector to help with the marketing or something like that, because the village can produce the product, but they don't know where to sell it. So the private sector come and help. It's help a lot. So it's like, for example, when we have the problem with the falling the crop price or something like that, the private sector come in and help on this in terms of how to find the market and how to manage it and how to use more advanced technology to help in terms of marketing and selling, so something like that. So now we have that kind of collaboration, but it's just started pandemic. I think that we will have more kind of this collaboration, and maybe they can come up and help us with in terms of the long-term care, because in the past long-term care was done mainly by the government, but in the future maybe the private sector will come in and help. Yeah, because we have the problem in terms of the long-term care financial stability. So we may have some kind of insurance or something like that for long-term care insurance that maybe we need from private sector to help us. Yeah.
Joelle, do you have an example from the private sector?
Yeah, sure. Turning back to the jobs and job loss created by the COVID-19, what we have is something called SG United Jobs and Skills Package. So what happens is that the government will work with employers, including private sector employers, to actually try to keep the local workers, especially those who are age 40 and above. And these are the people who have problems finding a new job. So we try to keep them through an eligible reskilling program that is funded by the government. So really the emphasis here is on lifelong learning, upskilling and reskilling. And for each worker that's hired, the employer would actually receive a 20% salary support for 6 months, capped at a certain amount from the government. So this really incentivizes employers to keep some of their older workers during this crisis.
So I would just say that I find most challenging about this time together is that it comes to a close so quickly. And it's nice because we're on a webinar, and so if we go a few minutes over, it's okay, but I want to be respectful to you and to our listeners in terms of timing, and so we'll need to close. But Harold, I wanted to see if you could comment just quickly on this point about institutionalization and deinstitutionalization. I was struck when you mentioned our success at the deinstitutionalization related to disability, but I feel like when we think about aging specifically, it's really gone in another direction, where we're thinking much more about residential care facilities and nursing home context. And you make the point that, right, in the context of COVID, it's really been incredibly risky and resulted in a higher rates of mortality. I just wondered why we might see that bifurcation. And if you could close us with that comment, I'd really appreciate it.
Wow, that's a responsibility. I think to have people thriving in their communities requires an infrastructure of supports that is a challenge. And I think many Americans turn to institutional care because we are just really concerned, are my needs or my loved one's needs going to be met outside of an institution? Who's going to be feeding my loved one? Who's going to help my loved one take a bath? And all of these very practical needs that people have. And if we want to move people out of institutions, we need to take that sense of empathy, in the sense that people do not want to live in institutions. They want to be in their community. But we need to be serious about what's the blocking and tackling to make that work. And when you were mentioning public-private sector, the private sector has a set of skills in how to practically execute critical tasks. Like you look at Amazon and its ability to get food to, who is feeding people during COVID? I think the honest answer in the United States right now is often Amazon. That it is bringing a truck to your house. You could live in the middle of nowhere in rural America, and Amazon has figured out how to get you your food so you don't have to move to live with your child. We need to be thinking in a much more intentional way. How do we make living in the community feasible for seniors and for the families of so that there's a real credible alternative to that institution? Because right now, often that alternative is not safe, is not credible. And I think that's the challenge that we have.
That's a terrific summary statement. And I think we walk away from this conversation imagining that a social safety net, right, takes on lots of different shapes and sizes and emerges from many different forms of collective and community engagement. So Vipan, Joelle, and Harold, thank you so much for your time, and I'm sure you're available to our listeners if they'd like to send you a question via email.
And thank you
Absolutely.
very much.
And
Thank you so much.
Yeah, I really enjoyed this conversation, and listeners, please join us on July 30th. Thank you so much.